नमस्ते बिटिया, हमेशा खुश रहो बिटिया. This is the series of respiratory disorder, and in this series today we are going to continue with the previous lecture of chronic obstructive pulmonary disease. So this is the second part of COPD. In the previous lecture we have discussed about the general etiology, pathology that is involved, the definition of COPD, etiology, the pathogenesis, the various predisposing factors that are responsible for the development of COPD, the various examinations that could be done. We have also discussed about emphysema. In today's lecture, we will be discussing about chronic bronchitis, and also we will be discussing about general investigation and management of COPD, including management. So today we will start with chronic bronchitis. Chronic bronchitis is a disease that is characterized by hypersecretion of mucus sufficient to cause cough and sputum for most of the days for at least 3 months in a year for 2 or more consecutive years in the absence of any other respiratory or cardiovascular disease. This is important, hence I will again repeat the definition. COPD is in COPD, the chronic bronchitis is characterized by hypersecretion of mucus sufficient to cause cough and sputum for most of the days for at least 3 months in a year for 2 or more consecutive years in absence of any other respiratory or cardiovascular disease. The larger air passages are affected. Later, small airways are affected, producing obstructive features. Infectious causes, aggravations of the symptoms and sputum become prevalent. As the airway obstruction sets in, emphysema becomes together, known as chronic bronchitis emphysema syndrome. In short, written as CEBS. What is the pathology of chronic bronchitis? Bronchial mucosa shows hypertrophy and increase of mucus glands and goblet cells with overproduction of mucus. The distal airway shows narrowing of the lumen. The mucosa becomes ulcerated, and when the ulcers heal, the fibrosis occurs, as resulting in distortion of lumen with stenosis and dilatation. Distortion of airway leads to permanent obstruction. Secondary infection occurs in the later stage. The ciliary movement is impaired. The clinical features of chronic bronchitis. It depends on the severity and duration of the disease. Cough recurring year after year, especially in winter months, later becomes constant. The expectoration is mucoid and the sputum is tenacious, especially on waking in the morning. There is tightness in the chest. How will you make the diagnosis of COPD? Some of the features of chronic bronchitis we have already discussed in the previous lecture. So this diagnosis is common for emphysema and chronic bronchitis that are commonly known as COPD. History of chronic cough, mucopurulent sputum. The X-ray is normal in initial stage. The lung function test shows reduction in vital capacity, increasing in closing volume, and features of airway obstruction. The pulmonary function testing shows airflow obstruction with a reduction in FEV1 and FEV1 by F. The spirometry values are markedly reduced. Complications. What are the different complications of the cases of COPD? Frequent respiratory infections, respiratory failure, and right-sided heart failure. Management. How will you manage a case of COPD when he is coming to you? It is divided into few parts. Number one, general management. In the general management, we will suggest the patient to stop smoking. So, smoking cessation. Improvement of the general health of the patient. Regular exercise. Deep breathing exercises. Adequate sleep. And treatment of obesity. The specific treatment consists of stable phase COPD. There are three interventions. The first one is similar to the general management, that is smoking cessation. Oxygen therapy in the chronically hypoxemic patients. The lung volume reduction surgery in selected patients with emphysema. What are the medications that can be given in the cases of COPD? So, pharmacotherapy. Current therapies are directed at improving symptoms and decreasing the frequency and severity of exacerbations. Bronchodilators can be given. Anticholinergic drugs, which consist of ipratropium bromide, improves symptoms and produces acute improvement in FEV1. Beta antagonist, they provide symptomatic relief. Inhaled corticosteroids, they provide apparent benefit from the regular use of inhaled glucocorticoids on the rate of decline of lung function. Oral glucocorticoids, these are not recommended because they are having significant side effects, including osteoporosis, weight gain, cataract, glucose intolerance, and increased risk of infection. Lung volume reduction surgery, that is known as LVRS. It offers both a mortality benefit and a symptomatic benefit in certain patients with emphysema. The last treatment consists of lung transplantation. General medical care of the patient with COPD. The patient with COPD should receive the influenza vaccine annually. That is the polyvalent pneumococcal vaccine. Pulmonary rehabilitation. The treatment program that incorporates education and cardiovascular conditioning. The patient should be asked about fever, change in character of sputum, any ill contacts, and associated symptoms such as nausea, vomiting, diarrhea, myalgias, and chills. Inquiring about the frequency and severity of prior exacerbations can provide important information. How will you manage the acute exacerbation of COPD? Number one, bronchodilators. Typically with an inhaled beta antagonist, often with addition of an anticholinergic agent. Antibiotics for potential respiratory pathogens. Glucocorticoids to reduce the length of stay, to hasten recovery, and reduce the chance of subsequent exacerbation or relapse. Oxygen, O2 is to be supplied to keep the arterial saturations greater than 90%. Mechanical ventilatory support. The initiation of non-invasive post-positive pressure ventilation, that is NIPPV. Now we come to homeopathic management. Although homeopathic management consists of constitutional treatment, that is provided on the basis of totality of symptoms after proper analysis and evaluation and repertorization of the case. A single medicine is given according and the potency is selected according to the susceptibility of the patient. A minimum dose of the selected medicine is prescribed to the patient, but there are certain other remedies which are having very good role in the cases of COPD. So we are going to discuss some of them. Antimonium arsenicum. It is an excellent remedy for COPD with emphysema. There is excessive dyspnea with cough and much mucus secretion. It is worse on eating or lying down. Antimonium tartricum. It is indicated in emphysema of the aged, coughing and gasping consequently. There is great rattling of mucus in the lungs and rapid, short, difficult breathing. Aspidosperma. It is one of the best remedies for COPD and it is considered to be a tonic for lungs. It removes temporary obstruction to the oxidation of blood by stimulation of respiratory centers. Another guiding symptom is want of breath during exertion. Bryonia alba. It is an excellent remedy prescribed when there is frequent desire to take long breath. Must expand lungs. There is a dry, barking cough that is worse at night. Respiration is quick, difficult, with pain in the chest, worse by motion, and better by absolute rest. Coca. It is prescribed for COPD where there is want of breath or shortness of the breath. It is specially useful for aged sportsmen and alcoholics. There is hoarseness of voice and dyspnea. Curare, where there is threatened cessation of respiration on falling asleep. Short breath, short dry cough, and very distressing dyspnea. Lobelia. It is indicated in COPD where there is coughing with vomiting, asthma preceded by prickling all over the body, hyperventilation, panting, threatening with suffocation, fear of death, chest feels constricted, and worse from any movement. Naphthalene. It is indicated where there is dyspnea with sagging respiration. It is useful for emphysema of the aged with asthma. There is a long and continuous paroxysm of coughing and tenacious expectoration. Seneca. Seneca is an effective remedy with increased respiration. There is excessive dyspnea and sharp contractive pains in the muscles of the chest. There is persistent cough. Strychnine. Strychnine as the respiration increased. There is excessive dyspnea. There is sharp contractive pains in the muscles of the chest and persistent cough. So these were the medicines that are commonly indicated in the cases of chronic obstructive pulmonary disease. In this, we have discussed about emphysema and chronic bronchitis. What is the definition? What are the clinical features, the pathophysiology, and the investigations and management. In the next lecture, we will be discussing about tuberculosis. This session was powered by Digital Version 2.0, Jayoti Vidyapeeth Women's University. I hope you are satisfied with my digital session. If you have any query, please mention it in the comment box. I will try to resolve it. So this was all for today. Thank you very much. Myself, Ravi Jain, saying goodbye to you. We will meet in the next talk. Thank you very much.